Wonderful. Okay, so airline travel and home ventilation, things to consider. So the first thing that I want to say, are my slides moving forward, Jill? Right, wonderful. The first thing that I want us to be aware of is that whilst I'm going to talk a little bit about um, concerns, worries, why we need to be careful, what I really, really want to stress is how important it is to me, to my colleagues, to those of us on the call, to support, encourage, and enable people who have disability or reliance on technology to continue to enjoy the things that you and I take for granted. And the hashtag adding life to yours, which is one that we very often use in the home mechanical ventilation in partnership resource, because we're not about, you know, restricting people from doing things. It's about empowering and enabling, but with care, careful planning and with care. So these are all people that we have looked after. I've got permission to use these slides. All people who use non-invasive or invasive ventilation, doing things that we do during the summertime every year. It's probably where they are now because they're not on the call. So why do we worry? When you undertake commercial airline travel, you will be at a cruising altitude of about 35,000 feet. However, the cabin is pressurized to about 8,000 feet. And the reason for that is that we know that that keeps the concentration of oxygen within the cabin at a certain level. Now, the oxygen dissociation curve is the picture that you can see on the screen. And whilst you don't need to know exactly what this means, if you look at where the 90% mark is on the left-hand side and how the curve kind of flattens between 90 and 100%, what that tells you is that there's not a great deal of value between having your oxygen levels at 90%, 95%, 98%. There's not very much bang for your buck between those levels. You're above 90%, you're safe. And the cabin being pressurized at 8,000 feet will keep most people with healthy lungs at an oxygen saturation at a safe level of 90%. The importance of the oxygen dissociation curve is that once your oxygen saturation levels, your blood oxygen levels begin to fall below 90, 85, 80, you can see that the fall is very steep and very rapid, and that's when it becomes dangerous. So we know that keeping the cabin pressure at 8,000 feet, keeping that oxygen concentration to maintain the pilot, the cabin crew, all of the passengers on the plane, keeping our blood oxygen levels at 90% or above is perfectly safe. For people who have respiratory disease of any description, whether it's reliance on home ventilation or any other respiratory disease, these small changes can have significant consequences, and that's the reason that we worry. Now, to illustrate that, what you're looking at here is me on a flight to Spain. So this is a 3-hour recording of my oxygen saturations and heart rate. The heart rate's in blue at the bottom. You can kind of disregard that a little bit. Up the left-hand side of this scale, you can see 100% at the top and then going down 90, 80, 70% on that axis. When I'm sitting on the tarmac, my oxygen saturation level is sitting at about probably 96, 97%. Along the bottom axis is time. That's the 3 hours. So I know it's 3 hours because I know it was Spain. So if you can imagine the first 30 minutes of what you're looking at there, my oxygen saturations fall from about 96, 98% down to 90%. And that's as we cruise up to altitude. Once we're at altitude for the duration of the flight, you can see that whilst they move around a bit, which is normal, I did go down to kind of 88, 87% at times. I went up to about 92% at times, but I was sitting in between and I've got no underlying health problems, no lung disease. I'm not a smoker. And this is what we would see. As we come towards the end of the flight, for the 30 minutes as we start to descend and come back to land, you can see that my oxygen saturations come very nicely back up to the pre-flight level. Now that's real. That's not speculation. This is what happens to our blood oxygen levels during flight. So obviously, if you've got a breathing problem, there's a chance that that might be very different. And that can result in medical problems during the flight. And this is what we want to avoid. The images across the top there are just newspaper clippings from various things that have happened that have resulted in flight diversion. The consequences of flight diversion are widespread, huge, and variable. Obviously, there's significant expense, which will have to be met by somebody, hopefully adequate health insurance. There's inconvenience. I mean, none of these are in any order of priority, I hasten to add. Um, but being inconvenienced, time away, going on holiday, it's precious. You might only have a week. The last thing you want to do is to be diverted to another airport and lose half a day or a day of your holiday. There's environmental consequences of flight diversions, obviously, because they're having to travel a much greater distance unnecessarily. Massive challenges to the airline crew. It's not good for the airline crew, although they're trained to have to deal with medical emergencies. It's a really vulnerable and causes a lot of anxiety for them. It's distressing for other passengers who are there and witnessing medical problems happening during flight. And ultimately, and most importantly, it could result in patient harm or even death. But that doesn't mean that it shouldn't happen. Now, this paper is quite old. This is from 2007, and I'm not going to go through the detail of the paper, but ultimately, commercial air travel is safe provided appropriate assessments are made and careful planning takes place. That's the most important thing. And that's the message that we want to get from this particular paper. In terms of how do we know what that planning and assessment process should be? And this is the guidance that we use is from the British Thoracic Society. The original guidance was written in 2002, and that was Rabina Stoker, who has led on all of this. She's a respiratory physician in London. This guidance tells us what we should be doing to support patients who have respiratory disease to undertake airline travel. The guidance was revised in 2011 in light of new evidence. And then in 2022, the most recent publication, which was a clinical statement, was published to again support us as clinicians to give the appropriate guidance and do the appropriate assessment on patients who wish to undertake airline travel. There were quite a number of key changes in the most recent clinical statements in 2022, but the most important area of change in relation to this call is that previously the guidance focused on patients with COPD or diseased lungs. What the 2022 clinical statement has done, it's included guidance for those that have other areas of respiratory impairment, including those that use home mechanical ventilation. What the guidance says is that all patients who have any kind of respiratory impairment should undergo careful assessment. Now, the assessment could be from your GP, from a number of healthcare professionals to review your current status, your current health status, what treatments you're currently receiving, what symptoms you've got, how things went when you previously travelled, were there any problems, were there not? And importantly, which I'll come to in a bit more detail shortly, consideration of the logistics of the intended journey. And when this sort of preliminary screening raises concerns, that's when specialist respiratory assessment should take place, and that may include a hypoxic challenge test. I'm going to talk about what a hypoxic challenge test is, but just to note that in our service, in our home ventilation service, we perform a hypoxic challenge test on all of the patients under our care. Anybody who has chronic respiratory failure, which are those that use home mechanical ventilation. And that's because there has been a bit of evidence to suggest that it's very hard to predict which patients are going to require supplementary oxygen during flight. It's not easy to predict that. Now, the hypoxic challenge test. Sorry, there is a phone ringing in the background. It will stop in a second. Stop now. The hypoxic challenge test is often referred to as a fit to fly test. It is not a fit to fly test. It's very difficult without the aid of a crystal ball to predict whether somebody is or isn't fit to fly. What the hypoxic challenge test does, it assesses whether or not supplementary oxygen is going to be required during flight. What happens during what I call the flight assessment clinic that I host and my colleagues host here in Newcastle, what we do during that test is we talk a lot about other aspects of the journey and give information and guidance to our patients that will help support them to have safe airline travel. But this is not fitness to fly, and the hypoxic challenge test is specifically to see whether or not supplementary oxygen is required. And this is what it looks like in practice. This is somebody sitting. You can see that they've got an oxygen mask, which has what's called a 40% venturi, which allows a bit of air in to dilute what they are breathing. The cylinder that's beside them is not oxygen, it's nitrogen. So in the atmosphere, in the air, at the moment at sea level, there's about 21% oxygen. The rest of the 79%, give or take a little, is predominantly made up of nitrogen. And what we do during this test is we flip the balance a little bit. Using nitrogen as the driving gas means that the person receiving the hypoxic challenge test gets less oxygen. And it's a very protocol, evidence-based procedure which simulates 15% oxygen being breathed by the patient, which is pretty much what you will be breathing at altitude with the cabin pressurized at 8,000 feet. Now, for patients, particularly who have neuromuscular disease, there's quite a bit of evidence to say that giving supplementary oxygen unopposed, and what we mean by that is without any additional breathing support, so without a ventilator to offer breathing support to move the lungs, just giving oxygen on its own can, not always, but can be harmful. Without going into the specifics of why that happens, the evidence, the papers that you're seeing written at the bottom there, one was a single case report. The one on the right-hand side was a small number of patients with neuromuscular disease who were given low flow oxygen, so not high levels of oxygen, low flow oxygen. It was a retrospective review. And after receiving low flow oxygen for a fairly short period of time, their carbon dioxide levels went up by an average of 3.8 kilopascals. Now, for those of you that might not be familiar with what that means, a normal carbon dioxide level, if I was to measure all of us on the call, it would probably be somewhere between about 5 and 6 kilopascals. Could be in the fours. That would be perfectly normal and safe. Once you're getting up to 6, 7, 8 kilopascals, that is dangerous. And it means that you're retaining too much carbon dioxide in your blood. So an increase of nearly 4 kilopascals on top of normal is going to take somebody up to 9 or 10 kilopascals. So receiving oxygen without breathing support can be dangerous. And the way we get around that, if we feel that somebody, having had the hypoxic challenge test, needs to have supplementary oxygen during flight, we would do the test with oxygen on, but with this monitor that you can see on the screen, which measures their carbon dioxide levels. So we repeat that test and it'll tell us whether or not they retain, because not everybody does, whether they retain carbon dioxide. And that informs us and helps us make the appropriate recommendations. Now, following on from that a little bit, and this is kind of where the background ends, and the next slide will start on more practical advice. For people who use ventilators 24 hours a day, or even 12, 15, 18 hours a day, that is going to mean that they will be on the ventilator during the flight. At the moment, there is no evidence-based way of performing that hypoxic challenge test that I showed you in the previous picture. There's no way of doing that for somebody who uses a ventilator. The apparatus with that oxygen mask, the 40% venturi, the nitrogen cylinder running at a certain flow rate is the only way it can be done. The images that you see in the screen are some bench testing that my colleague and I have done in Newcastle and have now used this on a good half a dozen or 10 occasions for patients who require ventilation during the flight to allow us to test whether or not ventilation alone without supplementary oxygen would be adequate to keep their blood oxygen levels at a safe level. But I'm not advertising that as an evidence-based approach. We've bench tested it, we've used it. It's meant that we can give our best advice to the patients who are traveling. Now, if somebody does require supplementary oxygen during flight, things have changed, and not for the better, for the worse. It was starting to change a little bit pre-COVID, and then during and following the pandemic. Obviously, there was no travel during the pandemic. Following the pandemic, with limited oxygen supplies during that time, and I think a little bit, my cynical head, a little bit about cost to the airlines. It is now rarely possible to have oxygen provided by the airlines. If I was to go back 7 or 8 years, some airlines, Virgin Atlantic, TUI, a lot of the major airlines would supply oxygen provided it was requested in advance, and there is a process for that. They have all stopped. I've come across 1 or 2 airlines who provide it. Ryanair, bizarrely, is one of them. But it's very difficult now to get oxygen provided by the airline. The budget airlines, Jet2, EasyJet, didn't ever provide oxygen, but would allow you to take a small cylinder because they were only short haul. They would allow you to take a small cylinder, which you could prescribe, us as clinicians could prescribe on the NHS. You would have 1 cylinder for going out, 1 cylinder for coming back. We're not allowed to prescribe oxygen for holiday use on the NHS anymore. So any oxygen required by our patients who require it for travel purposes has to be at their own expense, and it's a privately hired system and a contract between the patient and the provider of the oxygen. It would be something like what you see in the picture. This is a portable oxygen concentrator, which is run by battery. It's about this big. But they are not cheap. And if you're traveling a long journey, for example, to America, where the flight might be 8 or 9 hours, you need multiple batteries. You might need 7 batteries to power this device, which have little cells which have to be changed over, and that increases the cost. So it's a huge expense to the patient, and something that I feel very strongly about when we're trying to enhance quality of life with a treatment like long-term ventilation, and then we, by virtue of the patients not being able to afford to travel, we then inhibit their ability to enjoy a good quality of life. So please write to your MPs or anybody that you feel is prepared to listen to lobby that point, because hopefully one day that will change. The point at the bottom, if ventilation and oxygen are required, which it may be the case, the machine that is required to do that needs to be continuous flow. So the oxygen needs to run continuously rather than pulse dose, sometimes called on demand. Pulse dose and on demand only pushes oxygen when the patient inhales. So when the patient exhales, there's no oxygen delivery. So it halves the amount of oxygen required by 50%, which means the battery lasts 50% longer. So there's lots of reasons behind that. But this pulse dose oxygen, which just when the patient breathes in, is not compatible with non-invasive ventilation. So it can't be fed into the ventilator. That has to be continuous flow oxygen, which is a more expensive concentrator and is more expensive because it requires more batteries, because the batteries need to run it for longer. So just lots of things to bear in mind in terms of oxygen. Whether oxygen and or non-invasive ventilation are required during flight, most airlines will require a medical form to be completed. That's just the Jet2, a snapshot of the Jet2 example. There are 2 parts to most of the medical forms. Part 1 requires completion by the patient, and Part 2 requires completion by a healthcare professional. And in Part 2, it will ask questions about the equipment, the technical specification of the ventilator and or oxygen, the flow rate, and what's required. And it will also ask the clinician a bizarre question, which is usually phrased prognosis during flight. And that's the airline asking the clinician, is this patient going to be okay to fly? And we make a best judgment on that, provided all of the things that I'm about to go through are in place. So if you are planning to book a holiday, check with the specific airline that you're traveling with what their requirements are. The all of them, they're called a MEDIF, the medical forms, MEDIF. All of the MEDIFs are airline specific. So every airline has their own MEDIF that require sometimes very brief, sometimes very lengthy information to be completed. Some airlines, TUI for example, don't have a medical form. They require what they call a fit to fly letter. It's a bit of a bugbear of mine, but that's what they ask for. They ask for a clinician to write a letter to say this patient will be fine to fly provided X, Y, and Z are adhered to. Once this medical form is filled in with whatever information and whatever recommendations have been made, it goes to their medical clearance department and sometimes to their aviation engineering team to make sure that the device and often the battery, because it's the specification of the battery that the airlines worry about, as you probably know, to make sure that that's all cleared for flight. I would make sure that they have added that to your booking and that you've got something written that says that clearance has been provided by the airline. Because whoever you speak to on the phone, whoever is at the travel agent desk that says, oh, yes, yes, they've said it's fine, will not be at the airport when you're checking in. They will not be on the plane when you're trying to use your equipment. So make sure you've got something in writing to say that that clearance has been provided. And just to bear in mind when you are using equipment, the airlines will require both the oxygen concentrator that I just showed you in the previous screen, if required, and the ventilator have 150% of the flight duration in battery performance time. So if it's a 3-hour flight, you will need 4.5 hours of battery performance time in whatever equipment you're using, and that's to cover for any delays, flight diversions. So practical hints and tips, what other considerations are there? So I want to know from my patients who I'm supporting to travel the time and the duration of the flight. So are they flying um, during the day? Because that would be my recommendation. Most of our patients, not all, but most of them use ventilation at night time. So the idea of traveling during the day means that you ought not to require your ventilator during the flight. So think about that carefully. And I'll often get a patient that comes back and says, I did exactly what you said, Alison. I've booked a daytime flight. It's at 6 o'clock in the morning. Okay. So you've got to be at the airport for 4 o'clock in the morning and you live an hour from the airport. So you're leaving the house at 3 o'clock in the morning, which means you're out of bed at 2 o'clock in the morning. That isn't a daytime flight because that's now eaten into a good part of your night. You might not even go to bed. So the time that we want you to be at your best, at your and optimized your respiratory health in preparation for going into an atmosphere that has low oxygen levels, you've actually eaten into that by not being able to use your ventilator for the whole night the night before. So think about those journey times carefully and the duration of the flight. How long is that going to last? I've said whether it's daytime, overnight. That's really important. It doesn't mean that overnight travel is not possible. If you go to the States, your return flight's probably going to be through the night. But that would mean that we'd recommend using non-invasive ventilation during the return flight. Um, Sometimes there are stopovers. Sometimes you're flying out of another UK airport. We might in Newcastle have people flying out of Manchester. I would encourage you to go to the airport the night before, get a good night on your ventilator, and ready for travel the next day, rather than getting up early in the morning, undertaking that 3 or 4 hour drive, and just eating into that important time on the ventilator. And always consider and factor in delays. We know that travel, worldwide travel, is fraught with delays for all kinds of reasons. So don't ever assume that that won't be the case, because we know from our own personal experience that delays are very, very common. Other advice that we give to our patients, um, we recommend that all of our patients take a spare ventilator with them when they're traveling outside of the UK, even if they're traveling to a different part of the UK, which is a long way away. If you use your ventilator every night or part of the daytime as well, and it broke down, if you're at home, we would replace it the very next day. But if you're outside of the UK, or again from Newcastle, you've gone down to Cornwall or Kent, it's going to be 8 or 10 hours before we can get a replacement to you with the best courier. So taking a spare one covers that eventuality. Probably, and I always say this in advance, probably you'll cart a spare ventilator with you. You'll curse me all the way through the airport to your resort and curse me all the way back as you cart this spare machine because yours never broke down. But like any insurance, if it does break down, it's worth its weight in gold, because if it broke down when you're on holiday, you would not be able to access a home ventilator. You might be able to get some breathing support and be admitted to hospital, but you would not be able to get a machine to use in your hotel, which means you could be 3, 4, 5, 6 nights, depending on when it broke down, not having any nighttime ventilation, then undertaking a flight where you'll be breathing low concentration of oxygen. So you're just making those risk factors worse. Somebody said to me very recently, I'm not going to take a spare ventilator this time because you told me to take one last time and I took one and mine didn't break down. So I'm not going to take one this time. And that's not how it works. So it probably won't, but if it does, it's really important you've got a spare. We provide a generic letter to all of our patients to request that their respiratory equipment is carried as hand luggage on board the plane. And this is partly in case they require access to it, but also in case it gets lost or damaged in the hold, because you don't want to get to your destination and find that your suitcase has not been well cared for and your machine is broken. If possible, depending on the country, it might be worth considering whether that needs translation into the language of the return airport. Um, we talk about other spare equipment. So some patients use a machine to augment their cough. Some patients use respiratory humidification. Some use nebulized therapy. There's all kinds of other respiratory equipment, not all of which might be required on holiday, but we have a conversation about it to make sure that that's been considered. And asking that they check compatibility of the equipment with the power sources outside of the UK or on a cruise, so that they've got the right plug adapters and that the compatibility is okay. Don't expect you to read that information on the screen, but it's just to say that the planning and preparation is really important. So the information that you can see on the left-hand side is just a little extract from a leaflet that we give to our patients when they begin to use home mechanical ventilation, so that they've got that advice about planning air travel. And then we also give out a leaflet in our flight assessment clinic, which gives all of the hints and tips that I've just gone through about things to consider. And that is to remain awake during the flight. Again, if it's an overnight flight, not practical, consider using ventilation. But if it's a daytime flight, remain awake. Most of our patients require ventilation during the night because we all underbreathe during sleep. So we don't want to subject you to low oxygen concentrations at altitude and then you go to sleep, because it's risk on top of risk. I recommend that our patients increase the use of their non-invasive ventilation before and after the journey. And what I mean by that is, if it's a 4 o'clock in the afternoon flight, have a spell on the ventilator at 11, 12 o'clock before you set off to the airport to give yourself a little boost. If you arrive at your destination at 2 o'clock in the afternoon, it might not be the time that you would normally use ventilation, but before you head out for dinner, just have half an hour or an hour on your ventilator again to give yourself a boost. Avoid anything that's going to make you sleepy, alcohol or anything with sedative properties, because we don't want you to feel drowsy, because then you won't breathe as effectively. Um, Travel insurance, so important, and make sure everything is declared. Even if you required hospitalization because you got stung by a jellyfish, if you haven't declared everything and all of your health problems on the insurance policy, then it won't cover, and it can be a very, very expensive outcome. And something which Chris on the call actually gave us a tip about is to check the small print and see if unscheduled diversions, flight diversions, or early return to the UK are covered. Because if you remember what I said at the beginning, the airlines will be looking to recover the huge cost of diverting a flight if somebody becomes unwell, and you want to make sure that your insurance is going to cover that. And my last Girl Guide trick is to take a roll of tape. If something's going to break, it'll be a piece of the mask, a piece of the tubing. Take a roll of tape just to bodge it together until such time that you can get a replacement or get home. So, just to begin to conclude, in Newcastle, Neves is the North East Assisted Ventilation Service, and in our flight assessment clinic, we have developed what we think is a robust structure to allow and enable patients under our care to undertake safe airline travel. And that includes a very structured approach, which is in line with national guidance. We provide informative patient leaflets. We do all of our hypoxic challenge testing ourselves. We provide any spare respiratory equipment that the patient requires to travel. We give guidance on whether oxygen and or ventilation might be required during flight, and the medical forms can be quite challenging to fill in, and we support the completion of those. And we've achieved these objectives. We've got no adverse incidents reported. Those news articles that I showed you at the beginning are not from Newcastle. And we've had some really nice and positive patient feedback, some of which you can see on the screen there, to tell us that our patients appreciate the way in which we manage the risk but enable them to travel. A little shout out for the home mechanical ventilation in partnership resource, which Jill and I are heavily involved with. This is a website. Please scan the QR code, go to the website. There's lots and lots and lots of information there, but there is a section on airline travel. And as well as some text going through some of the hints and tips that I've gone through on this call today, we've now recently added some videos of from other patients that have undertaken airline travel and how they've navigated that journey, because the people who understand the barriers, the difficulties, the challenges are the patients. I can give advice about what's the best way to keep you safe, but I'm not a wheelchair user. I'm not somebody who has to navigate that the difficulty of airline travel with disability. So I think you'll find the videos that are on there really, really interesting. And I shall finish where I started. More pictures of patients at the beach, out partying, enjoying being away with their friends despite significant disability and significant dependence on respiratory support. It can be done, it just takes a lot of planning. I'm very happy to be contacted. My details are on the screen there. If anybody wants any advice or support, I'm very happy to help in any way that I can. I'm going to stop sharing my screen now. I think, Jill, you're going to stop recording, and happy to take